Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. It's our opportunity to bring some anterior segment information to our audience. Anterior segment disease, what every optometrist should know, by Dr. Deepak Gupta. Deepak Gupta has been in private practice since graduating NUENCO in 1999. He handles all aspects of primary care with emphasis on disease management, glaucoma, and keratoconus. He is an author of a textbook on glaucoma, and he is also produced and directed for Scary Night Productions. Deepak provided a very brief bio. Most humble people do something like that. I will tell you a little bit more than he would. I've known and worked with Deepak for a number of years, and I can tell you he is one of the most professional gentlemen that I've ever worked with in the profession. He is also what I call a doer. You know, besides filming his own movie, he has written a textbook on glaucoma. He runs an educational company, much like we are with Optometric Education Consultants, and he's published novels. Deepak, how many novels have you done? I've read the first one.
I've done 3.
You've done 3. I've got to get caught up. I read the first one. I thought it was really very good. So when I think of Deepak Gupta, I think of this is a person who's a doer. He thinks about what he wants and goes out and does it. So with that, he's going to do a tremendous lecture for us, anterior segment disease, what every optometrist should know. So with that, Deepak, please take over.
Thank you so much, Joe. Thanks, Joe, Greg, and Optometric Consultants for allowing me the privilege of working with you guys tonight. I really appreciate it. As Joe said, I graduated in school in '99. I've been in private practice, so I don't have any financial disclosures. Everything you'll hear tonight is all just me in terms of the way I practice. And, like I said, I've worked with Joe many years. When I present case studies and stuff, I never present information like what I have is the right answer. As we know, many times when we manage patients, there's more than one or right way or wrong way to handle patients. So we'll go through some case studies, we'll ask some questions, we'll all learn from each other. And I'd rather it be a discussion and an interactive forum. I'm sure Joe and Greg will have some comments as well, and I welcome those because I think we learn, the more people we have interacting, the more we learn from each other. And to me, my passion, like it's a joke, is about disease, it's about primary care optometry. I've been in private practice, so I like to do it all. I like to do glasses, contacts, keratoconus, surgical co-management, glaucoma. But anterior segment disease, to me, is easy. It's the most cost-effective way for optometrists to build a therapeutic practice. If you want to manage macular degeneration, you need to buy an OCT. You want to manage glaucoma, there's a ton of equipment you need to buy. For anterior segment disease, you don't need a whole lot. You just need your interaction with your patient, taking a proper history, doing a slit lamp exam, and just the willingness and the ability to be able to write prescriptions. You can do that. You can have a very healthy therapeutic practice without having much else. So to me, in private practice, these are the 3 most common anterior segment conditions we see: infections, allergies, dry eye disease. And certainly we see a lot more than this in everyday practice, but this is probably bread and butter for a lot of optometrists. So these are the primary things we're going to focus on tonight. And we'll go into a little bit of detail on each one of them, on how we can manage patients and get up to date on what's going on in each area and how we can, best help our patients with these conditions. So let's start with our first patient. Our first patient is a 24-year-old male who comes in complaining about red, irritated eyes. As many of our patients, unfortunately, even when they have an eye problem, some of them end up going to their primary care instead of coming to us. So this patient went to their primary care, was given erythromycin ointment 4 times a day, and really didn't get any better. And that's the point in which, unfortunately, a lot of these patients reach out to us and say, look, I went to an urgent care center, I went to a primary care, and didn't get the relief I needed. And that's when they're sent to us. So for our patient, you can see no significant ocular history, medical history, pressures normal by palpitation, undilated fundus exam is normal. When we go to our slit lamp exam, it's pretty easy. Obviously, it's just in terms of gross examination, our patient has red, irritated, inflamed eyes. And we're going to go through your normal differential. You're going to rule out all the other stuff. Once you do that, I came to the same conclusion that this patient's primary care had done, which this patient has some type of conjunctivitis. So what I did is probably what a lot of us have done, what I've done probably for 20 years now, is we tell our patient, well, your primary care prescribed erythromycin ointment. Erythromycin ointment works for many patients, but it's also a prescription, a drug that came out 20, 30 years ago. So let's put you on something newer or stronger, however you want to word it to your patients. And we do that, and our patient gets a little better. After a week, the patient's situation has resolved. So to me, before we go forward more with this patient, we want to stop and we want to talk a little bit about eye infections. We want to talk about red eye emergencies in general. And to me, we're talking about, it's been estimated there's roughly 1.5 to 2 million eye infections a year. When you think about how many people and what people that gives us access to in terms of being able to help and take care of, those numbers are staggering. And I think when we first look at this number, we think, well, who sees most of these patients? And our quick answer is always going to be, well, the ophthalmologists probably see them more than we do. And yeah, the ophthalmologist might see more than we do, but the reality is it isn't even the ophthalmologist. It's been estimated that 2/3 of eye infections are seen first by primary care or by urgent care settings. And collectively, ODs and MDs only see a third of them, 35%. So when I got out of school 20 years ago, I joined an ophthalmology practice. One of the things I learned, to me, was one of the most important skills is when you have any red eye emergency, the thing you want to do first is rule out the most dangerous things. Rule out the things which are going to potentially cause damage to that patient's eye or decrease vision. And once you rule those things out, then you can actually take time and say, hey, let's see, then you're going to be left with some red irritated eye, usually some type of conjunctivitis. Then you can actually slow down and say, hey, we'll find out how to manage this patient in a minute. So to me, the things I put on this list for any red eye emergencies, you rule out an iritis, you rule out an acute angle closure glaucoma, you rule out a corneal ulcer, a herpetic infection, a fungal infection, or a corneal foreign body / penetrating injury. And that's not a totally exhaustive list. Obviously, there's more things than that could be dangerous in terms of a red eye emergency. But those are some of the most common things you see that are dangerous that you want to say, let's account for these things first. And then we'll figure out if our patient, what type of conjunctivitis our patient has. So let's talk about the first thing on that list. How do we rule out iritis? You look at what the chief clinical features are of our patient with iritis. But to me, that's one of the first things you're going to do when you're doing your slit lamp exam. Look at that anterior chamber, look for cells and flare, look for chromatic precipitates. All those things are going to indicate that if your patient might have an iritis. If your patient does have an iritis, the bare minimum workup is vision, slit lamp. And the key component to doing a workup for a patient with iritis is the dilated exam. And a lot of people think, well, if it's anterior segment disease, why do you have to do a dilated exam? Why is the most pressing thing is because you want to make sure there's no posterior involvement in iritis. Even though 87, 88% of cases of iritis are anterior, you can't know that until you've dilated and you've taken a look at the retina. A funny example on that, when I first got out of school, we used to see tons of iritis. I was down in Stamford, Connecticut. Probably 3 or 4 times a month, we'd get patients with iritis. And I remember this one gentleman who was having these recurrent bouts, who was having an iritis flare maybe 3 or 4 times a year. And what happens with these patients, once they've had 1 bout or 2 bouts, and you take them through the management protocol, they get pretty good at figuring out, hey, I know I'm getting a flare up of my iritis. So I remember like the 4th or 5th time this guy had a flare up, he just called me on the phone. And usually I had a pretty strict protocol that I would never diagnose over the phone. I didn't care who the patient was, what they were complaining about. Anytime they called, if they had a problem, my answer was always the same. you have to come into the office. Dr. Gupta doesn't diagnose on the phone. So for this guy, I felt bad for him. Every flare-up of iritis means 2-3 visits. So by the fourth or fifth flare-up he had, I said, all right, you've already got a prescription for the cyclogel and the steroids. Let's go ahead and treat you, and I'll see you in a couple of days when you start to get better. Of course, this guy, doesn't make it 3 or 4 days. He comes in the next day saying his vision gotten worse and his eye feels a whole lot worse. So he was that patient who had, when I dilated him and took a look, I realized he had posterior involvement. That's when I realized, so I took a shortcut, kind of trusting the patient, kind of saying this guy knows what he's doing. And, of course, he had an okay outcome. He didn't have a bad outcome with this. But then went back to the basics, say, look, every single patient, if you suspect an iritis, you go ahead and dilate them. Next question is, not only do you want to make your diagnosis of iritis, you kind of want to make sure that there's no other causative disease, that's causing your patient to have a flare-up in iritis. And the question then becomes is, when do you order lab tests for these patients? And you can certainly make the case and you can say, look, anytime our patients have a flare-up of iritis, I'm going to go ahead and send the patient out for a medical workup. I tend to be a little bit more conservative than that. I found a lot of the workups I've sent out for patients end up not being very, don't produce a lot of results. So to me, and this is not an exhaustive list, obviously, once again, it's just general times where I'm going to say, these are probably patients you want to look at a little bit more carefully in terms of whether you want to recommend they get lab testing or not. In cases that are bilateral, if they're atypical, if they're recurrent, if they're not responding to treatment, if they're getting worse, any patient who's immunosuppressed, and sometimes patients that have some significant KPs, you might want at least consider saying, do you want to send this patient up for a full workup to see if there's any causative agent for that patient having iritis. When you do, once again, the list of diseases which can cause iritis, is pretty broad. When you look at some of the things on this list, juvenile rheumatoid arthritis, TB, Lyme disease, syphilis, sarcoidosis, like I said. So it is something you always want to keep in the back of your mind. If your patient's having recurrent bouts or atypical, or if your patient has any interest, your patient says, look, why did this happen to me? Certainly not a bad thing to say, let's work this patient up and see if there's any other conditions going on. Now, that being said, like I said, even though I said you dilate 100% of the time, most cases end up being anterior for iritis. Only 13% roughly are posterior involvement. And even though we send these patients for workups, even in these atypical cases or recalcitrant cases or severe cases, more than half of them end up being idiopathic. So there's a lot of those patients who are having these bouts of iritis. We never find out, if there's any other underlying condition that's causing this thing. And to me, when you start treating iritis, to me, you have 4 different goals of treatment, and most of them are pretty obvious. Number one, you want to make the patient more comfortable. You want to get that patient's vision better. And the way you're going to do that is you're going to decrease the inflammation. And lastly, like we've talked about, if you want to determine any underlying cause. When you go to treating these patients, it's pretty straightforward. You can add a cycloplegic agent, and you can use whatever your cycloplegic agent of choice is, and then you're going to want to add a steroid. When you add a steroid here you're not going to mess around with an Alrex or a Lotamax. Those are wonderful steroids for most cases of anterior seg disease. For an iritis, if you can get the patient on a Pred Forte or a Durezol, that's great. If not, some of the other ones, the FMLs, the dexamethasone are fine as well.
Deepak, before you move on this slide, I think I've got a question is, what really is available cycloplegic wise at this point? Greg, do you have any input on that? And Deepak, do you have any input on that?
In terms of physically available, like writing a prescription for?
Yeah, that we can actually get.
We can get cyclogel up here pretty easily.
Yeah, cyclogel 1 and 2. Yeah, I have that too. And atropine I always have. What about the home atropine and scopolamines? Greg, do you have any thoughts on that? I mean, are we able to get those?
Yeah, I think the answer is still yes, Joe. They're just going to they're going to have to be ordered in. But if I'm going to be messing around with homatropine or scopolamine, I'm just going to go to atropine to treat an iritis, which is probably a good clinical pearl. There's two medications, atropine and Zirgan, that I have my little mom and pop little Duncansville pharmacy right down the road always keep in stock for me. So I always go with the patient and wherever pharmacy they need and want that ordered. But I always have the local pharmacy have Zirgan and atropine in stock for me because pretty much if I'm going to treat an iritis, I'm going to go with atropine most of the time. So my 2 cents.
Greg, what you said, I love. I find a lot of optometrists don't do that. They're just going to write a prescription or e-prescribe whatever they're doing, and they're going to say, go wherever you want. If you've got a drug that's not always readily available, it's not a bad idea to pick a pharmacy that's close to you and call that pharmacist and say, hey, I'm going to be writing a decent number of prescriptions for Zirgan or atropine or whatever those drugs are. I'd appreciate if you try to have them in stock. If you do, then I'll send the patient your way. And that way the patient gets help, immediately, as opposed to having to wait 24, 48 hours to get some of these things in. And I find that's a really good way to manage patients. So I love that you do that.
And Deepak, a question came in. What is your dosage of atropine?
I don't, atropine, it depends on the severity. I mean, I'll do it at least twice a day, sometimes 3 times a day on these patients. My job is, at least on day one, I want to hit them hard. I want to get the steroid as frequently as possible. Even, the Pred Forte I would do every hour sometimes, the Durezol every 2 hours. Atropine at least twice a day.
I mean, I agree. When I start off, it'll be atropine twice a day for a week. And then after a week, I might taper it down to just once a day. And how often do you follow these patients, Deepak? I've got my own bias, but I want to hear what you say.
I will typically see the patient about 2 or 3 days after I start treating, just to make sure that they're headed in the right direction.
Mhm.
And after that, I'll cut that down to about once a week, once I make sure that they're resolving. And generally, it's about 2, 3, 4 visits, maybe 3 visits on the average later, where they actually stabilize and they're actually you can start thinking about when to take them off medications or when to at least slow it down.
Yeah, I agree with you. I'm going to probably be 3 days to a week. My clinical pearl is don't follow these patients too closely. Daily follow-up of uveitis is like watching paint dry. Today, there's 1,000 cells in the anterior chamber. Tomorrow, there's 998 cells.
No, I like that too. Like I said, my first visit is just to make sure that they're not getting worse. And after that, I find every week is fine. And even sometimes, as they get better, even slow it down a little bit every other week. But to me, this is the one pearl I have. I know when I went to optometry school in Boston, they harped so much on the negative effects of steroids. I find a lot of optometrists, even with steroids, are saying, look, patient's better now. I got to get him off. I got to get him off. To me, there's no hurry to get these patients off. I went through a couple of my early years when I was in a hurry to get patients off steroids, and sometimes you would get a rebound effect. Now what I find is usually by like that 3rd or 4th visit, when the patient's already stabilized, and usually by then I've already cut that patient down to about 4 times a day on that steroid. And Joe, like you were saying, maybe once a day on that cycloplegic agent. Then what I'll do is I taper really slowly. And it's what I use in my practice, which has worked really well. I'll take out a dose every week when I think they're actually done, and we're on the tail end of that iritis flare up. And I find it's been a good protocol. I know it's a little bit slower than most optometrists do, and it's probably a little overkill, but I'd rather take it slower than to hurry up and get them off of it and find I have a problem. But
Yeah,
you, Joe, right?
I think you're right on the mark there, because many people are not comfortable using steroids. I don't know about you all. The longest patient I had on steroids was 4 years. They didn't have any untoward effects. It took that long to treat their inflammation. That being said, people want to get them off steroids too soon. As cells go down, the dosage goes down. Well, the cells are going to come up. You really should start tapering only when you don't have any cells at all in the chamber.
Hey, another little clinical pearl that I'll point out is we know in most iritis that the IOP goes down. Someone comes in, they have a pressure of 18, the other eye is 12, the eye or the eye with the iritis. I kind of watch the IOP, as it goes, using the other eye as normal. When I start to see that IOP starts to normalize, because that uveal scleral tract is wide open during the immune response. And one of the little pearls that I like is watching the IOP. And as it starts to come up, then I know the inflammation is calming down. Don't hear that talked about much, but when I treat my iritis, when I see that IOP coming up, I really don't look at it as a steroid response. When it's 12 to 18, I kind of look at it as we're starting to quiet the inflammation down. Then over time, if it starts to get into the 20s, then it would be more of an IOP spike. So we can use IOP as kind of a gauge of how that inflammation is calming down.
Yeah, and the ciliary body is responding and recovering faster than the trabecular meshwork, and that's why the pressure goes up. A pressure rise after a week is usually not a steroid response. That's a very good point, Greg. Deepak, take it away.
All right. So
Hey, Deepak, try changing just the angle of your computer. There's been some people reporting that there's a high pitched sound, and see if that just kind of helps.
is that better?
So far, yes. So let's try that and see what happens.
Okay. So now we move on from iritis, move to angle closure glaucoma. It's one of the other differentials I said you should always.
Let me do one thing, and it did fix it. So I didn't know you were moving on from there. So let me just throw this out because I learned this in an iritis class, and we're not going to labor on it. Everyone can look this up. But I want you to look up immune privilege out there. And there are a few sites that have immune privilege. And it just happens to be that the eye is one of them. The testes is the other, the brain and the CNS. That means that when antigens get there, that they really shouldn't respond. Our gut, sometimes our intestinal tract from our mouth all the way down to, I guess, to our butt would be sometimes confused as immune privilege because we're always putting foreign types of antigens in there, meaning food, but we don't get an allergic reaction to it, unless you are allergic to maybe some shellfish and things like that. But your eye has immune privilege. Your brain has immune privilege. So one thing I want everyone to is look that up. And true, when you have iritis, know that the immune privilege has been taken over. It really shouldn't have cells and flare. The body shouldn't be reacting to it. So you have to scratch your head a little bit as why are there cells and flare in that anterior chamber? All right, Deepak, that's all I have.
Thanks. So we'll move on from iritis now. And one of the other differentials it said we want to rule out is angle closure glaucoma. And here, once again, telltale signs. You're going to get a patient who comes in typically saying they have had a headache or a dull ache over the eye. It could be a couple hours, it could be a day or two, depending on how long it's been bothering the patient. Steamy cornea is going to be easy. It's one of the few things that's going to give you that combination. And they're going to have that mid-fixed dilated pupil. And obviously the telltale time when you check their IOP, they're going to have elevated IOP. And I think this is always, the last one's kind of iffy. I get a lot of optometrists that say, well, if my patient comes in with a red eye, with a feared conjunctivitis, I don't really want to check their IOP because I'm afraid of contaminating the probe or whatever they're using. That's all fine. At the very least, you should at least be able to palpitate, but at the very most, you should be able to check a patient's pressure and at least rule out angle closure and elevated IOP as a cause of that patient's red eye. I don't think there's any downside to doing that. If you've got angle closure, obviously that's something that you're going to have to take care of in your office short term. What are you going to do pharmacologically? A topical beta blocker, will get you about a 20% IOP reduction within an hour. An alpha-GAN will get you 25 to 30% within 2 hours. Stuff you're going to instill in the office to try to decrease that IOP. You're probably going to want to use the CAI. A lot of states optometrists have oral privileges now. If you have oral, Diamox here is great. And when you go to oral, if you go to Diamox, you're gonna have a choice. You can do Diamox 250, you can do Diamox 500 sequels. And here you really want the Diamox 250. And the sequels, if you recall from basic pharmacology, are your sustained release Diamox. That's not what you want. Sustained release Diamox is more for long-term glaucoma care. Here you want the acute release. You want that IOP to come down as quickly as possible. Once that pressure, if you can get it below 40, now if it's pupillary block, which is what's causing that angle closure glaucoma, which it is in many cases, you can go ahead and add that pilocarpine, 2% or 4% for the darker eyes, to try to get that iris to pull back away from that anatomical angle. And that's the thing, you want to get this attack under control. You want to get the pressure headed in the right direction, and you're going to send the patient home with probably all 3 or 4 of these medications to try to keep it under control. Long term, a lot of these patients who have this anatomical narrow angle, who've had this attack, you're going to send out to a surgeon for a peripheral iridotomy. Pretty easy procedure, done in the slit lamp with just topical anesthetic. Surgeon's going to use that argon laser to punch a hole through that iris. Whole procedure should take 10, 15 minutes. And obviously the patient might be there a couple of hours, for the pre-op and the post-op. And then they're going to go home with some drops, some steroids, bromonidine, or topical CAI. The other question becomes, is the patient has it, very rarely, the acute angle closure glaucoma oftentimes is just one eye, but if they've got an anatomically narrow angle in one, you'll likely have it in the other two. The surgeon's going to very least take a look at that fellow eye and possibly recommend a prophylactic PI in that eye as well. Most of your surgeons, when they do this PI, this is what it's going to look like on a slit lamp. Most surgeons are going to put it superiorly, and that's the best place for that placement. Why? Because that upper lid will cover that hole. That way you don't get any ghosting or any reflex images coming through that aperture. Long term, the other thing you want to do is an optometrist. So if, let's say your patient has a PI, they're going to come back a year later for your exam. You want to make sure that that PI is patent, because sometimes over the course of time, they can scar down, they can close up. Very easy way to do that. Take your slit lamp beam, put it at 90 degrees, narrow it, shine it through the pupil. You should get that retro illumination. You can see on the picture there, you've got that little red reflex coming through the hole. That's an easy way for you to tell that your PI is still patent. That way you know that it's safe to dilate that patient. If you can't see that red reflex coming through the hole, at the very least, do gonioscopy, possibly send that patient back to a surgeon for another PI procedure. Other thing you want to rule out is ocular penetration. So one of the more serious things, like we said, for a red eye emergency. How are you going to do that? 3 basic ways. One is history. The patient has trauma, has a foreign body, has something happen to their eye. Taking a careful history is going to give you an indication whether you think there's a chance of ocular penetration or not. Easiest thing is you're going to be throwing some fluorescein into that patient's eye anyway. Any of my foreign bodies always document a negative or a positive Seidel sign. Once again, just to let someone know that you look for it and to make sure that there's no issue. And lastly is obviously dilation. If you're still not sure for whatever reason, or you want to confirm that the patient doesn't have any ocular penetration, dilate that patient, and that way you'll get a good look inside the eye to make sure that there's no signs. Herpetic infections, another thing you want to look for. Very easy. Once again, you're going to have already have stained that patient's cornea. Look for this dendritic pattern. If it's not there, it doesn't necessarily guarantee that your patient doesn't have a herpetic infection, because not all herpetic infections show up this way. To steal Joe's words, textbook pictures are only found in textbooks. So this is what we all memorize in Spalton and Kansky. You realize your patient may show a little different pattern than what we memorized, but at least be on the lookout for it and rule it out before you go to manage your patient. Once you've done that, and you've ruled out the bad things, the iridises, the foreign penetrating bodies, and all that stuff, now you can actually take your time, because now what you're left with, you're likely left with some type of a conjunctivitis, whether it's bacterial, whether it's viral, that you can take your time a little bit and figure out to be more precise. But now you're not likely going to have that patient getting significant damage over a short amount of time. when we talk about conjunctivitis, I know a lot of patients, the adult patients come in saying, I think I have pink eye, I think I have pink eye. In the adult population, it's estimated that 3/4 of what we call conjunctivitis is actually bacterial conjunctivitis. Only a 12%, which is viral. These numbers dramatically different in kids where it's the other way around. So a lot of what we deal with is bacterial conjunctivitis. When we went to optometry school, we all learned about some of these factors, saying, if your patient has a thick ropey discharge, it's likely to be bacterial. If it's a watery discharge, it's more likely to be viral, and redness and lymph node involvement. And that's all fine. That's going to give you a clue in terms of what direction you might be headed. I realize there's also a lot of overlap in symptoms. Number one, patients rarely come in and say, I've got a thick ropey discharge or a watery discharge. And just say, I have green junk coming out of my eye, doc, fix it. But just be aware that, your complaints don't always correlate with what's going on clinically. This is an easy question. Want to talk about what's the most important risk factor for the development of eye infections. So there's roughly, 1.5 to 2 million of them a year. Most significant risk factors wearing contact lenses, which makes sense. You stick your finger in your eye twice a day, then once in the morning to put them in, once at night to take them out. You're going to increase the risk of developing an eye infection. So how do we diagnose this condition? Most of us diagnose it, we roll the dice. We do a careful history, we do a slit lamp exam. So it's not purely just rolling the dice, it's not purely based on luck, but we also most of us don't take a more definitive approach to confirming our diagnosis, whether we think it's viral, whether we think it's bacterial. And what I mean by that is, what do we usually not do in clinical practice? We don't usually culture. Right? I've been practicing 20 years. I can think of a handful of cases where I actually sent the patient out for culturing for conjunctivitis. Vast majority of patients, we don't do that. We've taken our history, we've taken our slit lamp, we've done our due diligence in terms of ruling out some of the dangerous things, but we don't usually do it. And realize also that when we talk about culturing is not just one specific thing. It's not just like a blood test where you say, hey, go get a blood test. There's different media if you're going to culture, which you have to use. So you kind of have to have an educated guess on what you're looking for. So if you're suspecting a fungal infection, you're going to want to use a Sabarot agar. If you're suspecting a Campaniba, you've got a different one. If you're suspecting Haemophilus, you've got specific things. So it's not just and certainly you can plate on all of them and send them in, but you still have to do your due diligence as their primary care provider and say, let me try to narrow it down a little bit and see what specifically I'm looking for. And then if you want to culture, you culture. And to me, this is kind of like the case of when you send an iritis patient out for lab work. And when do you culture? To me, the two most common times we culture is when something in the history of the exam seems out of the ordinary. When you say, look, I don't think it's just a routine conjunctivitis, whether it's bacterial or allergic. I think there's something else going on. And this is probably the most common thing is when a patient fails to get better. When we put a patient on whatever medical therapy we thought the patient would respond to, it doesn't work. And then we've either got to reconsider our diagnosis, or at that point, maybe considering culturing and saying, hey, let's try to get some more information to find out what's going on. We start talking about specific antibiotics. We talk about the new stuff. And when you talk about the new stuff, you come out empty-handed, right? When you think about the most recent topical antibiotic, which was released on the market, which was probably what? Maybe Zymaxid, maybe Moxiza, and even those were just reformulations of old antibiotics and weren't even true new antibiotics. Even the Bezavance is now what, 10, 15 years old? And so both in topical and in orals, the number of antibiotics that are being developed, that are being submitted for FDA approval has gone down every year. There really aren't a whole lot of new therapeutic options out there for topical antibiotics, and there isn't really going to be anything revolutionary. So what we have now in our therapeutic optional for bacterial conjunctivitis is really all we're going to have. But let's throw this question out, what happens, I'd say bacterial conjunctivitis is what we see in the adult population more commonly than anything else. And the question is, what happens if we do nothing in these patients with bacterial conjunctivitis? And the answer is most of them get better, patients get better on their own. Patients that are treated with placebo, will get a cure in about 2/3 of patients, 65% of patients within a week. And some of that's the BAK obviously helping out. But even if you do nothing in most cases of bacterial conjunctivitis, patients are going to get better on their own. You look at the list, and we started out with a patient that was taking erythromycin ointment, and this is by no means an exhaustive list. Some of it's just more common stuff we use. And the question becomes is, well, how do you decide what antibiotic to choose for your patient? And another way to ask that is, which antibiotic is best? And I think if you ask 100 optometrists, you'll probably get 50 different answers in terms of what they think is best and what works better for their patients. There's a study done in clinical ophthalmology back in 2010, and there's a reference for it if you're looking to look it up. And this paper went through and looked at a bunch of different studies that had compared antibiotics for bacterial conjunctivitis. And it compared just about every single antibiotic that's on the market right now, whether it's your Moxiza, your Zymaxid, your Bezavent, your erythromycin, tobramycin. And what they found is that they're all the same. So every company likes to say, hey, our antibiotic is better than theirs. And, but when you do the science, there's really no clinical difference in terms of what antibiotic you choose.
Deepak,
So the next question,
a question came in. What about a betadine lavage in the office versus prescribing an antibiotic? What are our thoughts on that? Greg, you can share your thoughts there too.
I've rarely done the betadine lavage. I've done it for some cases of viral conjunctivitis. I find most patients, they do well with it clinically. They just hate it when they're in the office. Number one, what I find is you've got to do it early in the case of viral conjunctivitis within the first 24 to 48 hours for it to really help. And it's just intense. You've got to put an anesthetic in the patient because it stings like crazy. So I think it does clear up a viral conjunctivitis. I've never used it on a bacterial conjunctivitis. So it does work clinically. I just haven't found very many patients that are actually, at the time that tolerate it well. How you've done, Greg?
Yeah, I mean, I've done a handful of betadine lavages for various ocular infections, obviously the more severe ones that are out there, just trying to get control of it. Something that is not responding to just therapy. I get a lot of referrals into the practice. The key is it stings, it burns, it stains clothes. The key is when you're done, you're going to have to use some steroids because now you got dead bug laying everywhere. And then you're going to get an inflammatory reaction from the dead bug. But, I don't think it's, used, daily. I think it's one of those, it's a great point brought up by Craig there, that keep that in the back of your mind for these ocular infections. And nice little weapon to use. I heard a lecture the other day say about, who pressure patches now. Now, I just did 2 this month on a patient that couldn't keep a bandage contact lens in, wouldn't ever be able to keep an amniotic membrane, patched it for 5 days, healed the eye, patched it for the other day. So, we always kind of keep these little tools that you might not use that often. And that's where I'd probably put betadine.
Deepak and Greg, you can answer this as well. This is like a theoretical. If you're going to create a new antibiotic, what would be important to you?
I think resistance probably more than anything else.
Okay. Zero resistance. What else?
Yeah, you're going to do, zero resistance. You're going to do, frequency of administration, right? You want to have good
how about 5 times a day?
Yeah, that's a little too high, right? You want to go
Okay.
once or twice a day with something.
Mhm.
That's that. You want to have good penetration that's out there. And I
Right,
think
good
more importantly, you're
penetrance.
going to want to have good cost, affordable.
A couple dollars, and effective against MRSA. Would that be a good antibiotic to use?
Yeah, be a great antibiotic.
Yeah.
You
don't have to invent.
Joe, I actually like Greg's answer the best, in terms of cost effective.
Mhm.
I find unfortunately, a lot of these new things that come out, when they're brand name, it just costs prohibitive for most patients.
Mhm.
So no matter how effective it is clinically, it's just not practical to use some of this stuff until years down the road.
Well, there's this great antibiotic that is not in development. It actually exists. It's 5 times a day. It's a few dollars. Great penetrance, zero resistance, and most effective. It's called chloramphenicol. I know you're going to laugh about it, but in Australia and New Zealand, it's over the counter. They use it for everything.
Yeah, the aplastic anemia kind of probably got a little bit blown out of proportion. As I travel the world, I do. They always ask when I do a talk in the antibiotics, where's your chloramphenicol?
Yeah.
So
Yeah,
I
they
agree.
laugh-
Probably got
they
blown
laugh
out
at
of the
us.
water a little bit. Yeah.
Yeah, they laugh at us. I'm sorry, Deepak, continue, please.
Okay. So I said our antibiotic, choice really doesn't matter when it comes to clinical success. Almost everything out there, we like to think of, one antibiotic being stronger than another or whatever. They're all effective therapeutic agents. So that same study I cited, the clinical ophthalmology, went on to do the next step. And they said, what's the proper dosing? A lot of us, when we start out with bacterial conjunctivitis, we start out with 4 times a day. Joe was talking about chloramphenicol being 5 times a day. So that same study looked at dosing, and they took some of the antibiotics and they said, all right, what happens if you dose them twice a day versus 4 times a day, every 2 hours versus 3 times a day? And once again, the study found the same exact thing. As long as the patient got an antibiotic in twice a day, so roughly every 12 hours, every antibiotic was as effective as the other. So to me, clinically, it didn't really change a lot of what I did, because the way I look at it is I tell most patients 4 times a day for most of these antibiotics or bacterial conjunctivitis. And you figure the first day or two that patient takes it 4 times a day, right? Breakfast, lunch, dinner, and bedtime. By the time that patient comes back for a follow-up, which is typically 5 to 7 days later, that patient's lucky if we're taking it 3 times a day. Usually they've already taken it down to twice a day at that point anyway. And to me, that's okay, because I know twice a day for most of these patients, just for conjunctivitis, not for ulcers or trauma or anything like that, twice a day will be fine. But to me, when we end about conjunctivitis, the way I end is, our role in treating bacterial conjunctivitis is often overrated. Certainly, I would never tell a patient that. But the truth is, if we don't treat a lot of these patients, they're going to get better on their own. Really, no matter what antibiotic we use, as long as the patient gets it in twice a day, they're going to get better with. And this is the most common reason why we prescribe. It isn't really, it's based on the clinical science. It's because patients expect this to. They say, look, you diagnose them, you tell them they have this eye infection. And the most common question is, well, what are you going to prescribe to make it better? And that's the real reason why we prescribe in cases of conjunctivitis. Joe, Greg, any other comments? We'll move on from conjunctivitis.
No, I think we're good. And I'm watching the chat box. We're ready to move on.
The only thing I would add, Deepak, is a clinical pearl. Remember, exotic lifestyles often lead to exotic conjunctivitises.
I like that. I might steal that line from you, Joe.
Think of me kindly when you do.
All right. So we're going to move on now. We're going to talk about our next patient. The 22-year-old female presents with red, itchy eyes times a couple of weeks, no discharge, has had similar episodes every spring for the past couple of years. No ocular history, medical history, undilated fundus exam is normal. Cornea is nice and clear, anterior chambers deep and quiet, IOP is normal. A pretty straightforward diagnosis on this, especially with the history of the patient having this every spring for the last couple of years. So what I did with her, went ahead and diagnosed her with allergic conjunctivitis, gave her a prescription for Cerviate. And so what happens? She doesn't show up at the 1-week follow-up, which I had scheduled. She calls the office a couple weeks later to complain about the highest cost of medication. So she decided to go over the counter, and her eye still feels well. And then she wants to know why I prescribed this medication, which was so expensive for her. So let's talk about allergies and allergic conjunctivitis in this segment. Recent Gallup poll showed almost 50% of the population suffers from allergies. High percentage of those numbers, roughly 83%, have some level of ocular symptoms associated with these allergies. When we start talking about allergies, we're talking about a type 1 hypersensitivity reaction mediated by IgE. Four-step process. The first process is called sensitization, and this is the most important part of it. This is when the patient comes in contact with the offending agent. They don't have any clinical manifestations, but this is when the whole process gets started. And after that, the whole process is surrounding this mast cell. The membrane of this mast cell gets unstable. When it does, it degranulates, it releases that histamine. Histamine within 3 to 5 minutes will act on the nerve endings to cause itching. Within 5 to 10 minutes will cause redness and to cause the vasodilation. So a lot of patients, patients in this situation have a lot of things they can do without us. And that's why I break down our management of these patients. Patients with mild allergies, they can do cool compresses, they can do artificial tears. Sometimes just instilling those, diluting the allergens out will help the patient. A lot of patients will go to Nafcon, the Opcon, the Visine. These do work for patients. They feature an antihistamine that's usually combined with a vasoconstrictive agent. Doing that's what helps the redness, that's what helps the itchiness. So it will help the patient. Unfortunately, it's very short lasting. The patients are really going to get relief from allergies from these things. They've got to use them every 2 to 4 hours. And then you get this rebound effect from the vasoconstrictive agent that actually causes the patient to use more and more and to respond to it less over time. Next categories are things we used to be RX for over the counter. I think most of us are aware that Patanol and Betadine went from being a prescription product to over the counter earlier this year. Most of us, I don't know how many of you guys were practicing long enough to remember Zatador, back 15, 20 years ago, also used to be a prescription product. Things which still need a prescription, our Elasticapt, our Reprieve, and our Elastat. So really no different than the Patanol or Betadine. And when we think of these things as anti-allergy things, realize that they're actually combination products. So they have that antihistamine component, and that's what you're going to give your patient that quick relief. Patients are going to get the relief of the itching, some mild helping redness. The most significant component to me of these combination products, and it doesn't matter which one you like, they're all basically the same, is the mast cell stabilizing effect. That's what's going to get that whole allergic process under control. Unfortunately, it's going to take about 1 to 2 weeks for it to happen. So when you prescribe these things for your patients, let them know you're going to get some relief from this right away. So they're going to feel better short term. But in order to get to full therapeutic benefit, it's going to take up to 2 weeks for the patients for this drug to kick in and for really to get some significant relief from their allergies. Newest medication, Cerviate. It's basically an ocular form of Zyrtec, single-use vials, twice-a-day dosing. Clinically, I think it works really well. Greg or Joe, if you've had experience with it, my biggest experience with it up here has just been cost. You write a prescription for this thing and it's been $80, $90 for a pack, which is only going to last about a month, and that just makes it cost prohibitive for patients to get.
Really, Deepak, with the previously scripted medicines now going over the counter, I find it kind of hard to support or justify a scripted medicine. I don't know there's anything in a brand that is that much better to justify the cost or justify the work and prior authorizations. Greg, what are your thoughts here?
Yeah, I agree. There's probably maybe some, special circumstance out there where writing a prescription might be, the patient might have coverage at 100%, where then going over the counter, maybe with some of the Medicaid or Medicare, Medicaid type of plans that are out there in the patients. So, probably those patients we would maybe write a prescription for, but I agree, probably 99% of my patients were doing over the counter medications, and I'm not really sure what, the marketing side behind, the olopatadine molecule, which is Betadine, that seems to always been the optometry's, drop to go to over the counter. That's why Zatador, Deepak was right. Zatador and Patanol were both prescription drugs at one time, and Zaditor couldn't keep up, so they just went over the counter for the people who just wanted to go over the counter. And now eventually all these have gone pretty much over the counter, than the ones Deepak pointed out. But I'm not sure. Patanol came out first, and it was twice a day. Then they went to Pat a day, which had 14 hours of coverage, so they were able to call it Pat a day. And then they went to Pazeo that was 0.7%. And when they went over the counter, they put them all out there. And I'm not sure what's the marketing behind it. You know, one says twice a day, and one says extra strength Pat a day, which is the Pazeo. Yeah, I just tell the patients get the 0.7% that's out there, and that's the one I usually go with most of my recommendations. But you're probably, you're right, Deepak. They all probably work by stabilizing that mast cell.
It's funny that you guys say that. I take a little different approach, for allergies. I agree with you. Clinically, most people, particularly with Patanol and Betadine being over the counter, are going to do fine with over the counter products. I still like to prescribe when patients come in to the office. So what I do typically is I'll prescribe an older product, whether it's an Ellistat or Reprieve or Elasticaf even, which up here is very affordable for most patients. They can get it for $10 for, through their prescription plan. And the reason I like doing it is a little bit more patient control than anything else. Number one, I will educate them that there's a lot of options out there over the counter, and a lot of them may work for the patient. But I still like to write a script saying, look, to me, theoretically, this is a little bit stronger is what I tell them. So if they can respond to over the counter, if that's a more cost-effective approach to them, they're welcome to do that. And the bigger thing I like about it is, I don't like for any red eye emergencies to tell patients that they can self-medicate, because inevitably what happens is the next time they have a red eye emergency, they decide to do that same self-medication route as opposed to coming into the office. So I certainly don't want to deceive a patient. I want to tell them the whole truth and, take good care of them. But I always like to try to take it with a grain of salt, saying, hey, next time you have a red eye, you still need to come in and see me. It's not just you can go get a Visine or a Pet a day or whatever, by yourself. Because I find patients in general are poor judges of what, a red eye emergency is from one to the next. They all think they're all the same, which, we know, unfortunately, they're not.
Deepak, I'm going to back up just a little bit. And this is only because we had a question that came into the chat. And it goes back to the bacteria. What about bacterial resistance if a patient starts using the medicine 1 to 2 times a day below the MIC dosing?
I haven't had a whole lot of problem with resistance. Most people are not going to be on this antibiotic more than a week to 10 days at the most. Mm-hmm. And if you look at some of these studies, which I cited the one, but there's many studies out there that saying twice a day dosing is sufficient for a conjunctivitis, for any of the antibiotics. So as long as the patient's getting it twice a day and it's only for that finite 7 to 10 days time period, I haven't found resistance to be a huge problem.
People have that ingrained, but most of the resistance comes from antibiotics that are in livestock feed, and we're ingesting it. And the person who's using the drop, once or twice, or misusing the drop once or twice for a week isn't going to do a heck of a lot. Now, a person who's using 1 or 2 drops for a year, they could end up hurting themselves.
And Joe, I don't know what you've read also. The other part of that resistance, what I've read is, since we're going topical for most of these things, even in cases of resistance, you can overcome that because we get such a high concentration into the ocular tissues topically anyway. So there isn't really a whole lot of data out there on real resistance in terms of ocular conditions of conjunctivitis. There's a lot in terms of orally, like you said, a lot from livestock. But in terms of topically, I haven't seen a whole lot clinically.
Yeah, I lecture with a pharmacist. I think you guys know Tracy Offerdahl. She's at the school and she has her own little apothecary. And, I've brought this up to her and she just kind of says, look, we got to be careful with topicals. But that's not where the resistance comes from. The resistance comes from the orals.
So coming back to allergic conjunctivitis, so what happens sometimes if just the topicals aren't enough, very many options, certainly no reason why you need to give up. You can go to a soft steroid. I love doing that, going to a Lotamax or an Alrax, prescribing it or over the counter, whatever your patient wants with the Patanol, the Ellistat, whatever. After a couple of weeks, discontinuing that steroid, that helps. Sometimes if your patient has symptoms other than just ocular, you can recommend oral medications. Last resort, it's always, if the patient's really having a problem or not getting into control, nothing wrong with sending a patient out to an allergist for some allergy testing to try to find out exactly what your patient is dealing with. Which means when we end the conversation about allergic conjunctivitis, this is kind of what I was saying before. I don't like patients to self-medicate. I always like to write, if you want to write a prescription, you can make it cost effective for your patient by writing for an older product. Or if you want to write for a more current product, educate the patients on the high costs, and they might get better with over the counter anyway. And that way, at least you've already prepared the patient up front, saying yes, over the counter might work. If it doesn't, at least they have the option for a prescription. Any questions? We move on from allergic conjunctivitis.
Let me just give one pearl of the orals that are out there. And one of the, we know that there's Claritin, there's Allegra, and there's Zyrtec. And those used to all be over-the-counter medications. I remember the acronym ZAC, Z-A-C. And if you all remember the commercial Claritin Clear, right? Claritin Clear. Claritin is the weakest of all of those medications. And if you just go with the acronym ZAC, you've got Zyrtec, Allegra, and Claritin. So when it comes to treating allergies, if I need something I want to go, orally along with, topical, then I'll go in that order, or going by the severity. If someone just comes in and they're just miserable, boom, I'm going right to Zyrtec. Now, remember, as you go up, you're going to get a little bit of this crossing over the blood-brain barrier, creating a little bit of tiredness, sleepiness. So Claritin Clear is good. And then going up to Allegra. And then if you have to go to Zyrtec, that's the way to go. The next question that I usually get is, where does Zyzol fit in? Zyzol's kind of a prodrug of Zyrtec. And so they're kind of in that same area, but maybe don't create as much drowsiness as the Zyrtec. So, just remember ZAC, Claritin, Allegra, and Zyrtec, and that kind of goes the order. As you get more potent, you get a little bit more crossing over. These are all kind of the same derivatives of Benadryl that's out there. Benadryl really crosses over the blood-brain barrier. It's got a few other mechanism of actions, and that's why you get really tired with Benadryl. These are, don't cross the blood-brain barrier as much, and then you don't get the sleepiness. So FYI.
Greg, it's funny you say that. I always laugh at some of these commercials for Zyrtec and Allegra and stuff we used to see, and they call them non-sedating, which I find to be not true for a lot of patients. A lot of patients, they're all going to be sedating to a certain extent. Even with the Claritin, they're all going to get that tiredness, drowsiness initially when the patient starts it. It may be less than some of the others, but I don't think any of them are truly non-sedating.
Yeah, they do plug into those receptors. They just don't have a high affinity for them to create that. So, I agree. They kind of non-sedating, they are sedating or less sedating. So.
All right. If we're done with allergies, then we're going to move on to our next patient. 58-year-old female here for an unscheduled visit to irritation in both eyes. Been going on a couple of months. Tried artificial tears, PRN, got some limited relief from it. History of glasses with a history of early cataracts, hypertensive. Dilated exam is all normal except for a poor tear film and poor tear meniscus in both eyes. Dilated fundus exam is normal. So to me, it's a very easy diagnosis here. Patient suffers from dry eye disease. So that's what we're going to talk about in the next segment. And when we talk about dry eye disease, it's been estimated up to 8 to 10 million people across this country suffer from dry eyes. And you can see this is a survey done in OM about 6 months ago. And what percentage of the total patient base has dry eyes? You can see it's huge. There's a lot of people with dry eyes. It's probably even that 18 to 20 million people I talk about is probably underreported. It's a very easy question, who suffers more from dry eyes, men or women? very easy. It's a 2-to-1 ratio. You know, women suffer from dry eyes a lot more than men. Your most prototypical patient for dry eyes is going to be your middle-aged postmenopausal female patient, who's going to be the most likely to suffer from this condition. I think we've seen with COVID, you know, we've seen the incidence and prevalence of dry eyes increase. You know, a lot of us are staring more at computer screens and staring more at our phone. And I think that's been one of the biggest contributing factor. I've seen this survey here, you know, that's probably the most common reason why people are saying the prevalence of dry eyes has increased. Part of it is we're becoming more and more aware of it. You know, back 15, 20 years ago, nobody really talked about dry eyes. It was more just a here's some samples of whatever tears you want and don't waste my time. And I think both ophthalmologists and optometrists now are starting to say, look, you know, it doesn't just have to be a nuisance complaint on behalf of our patient. You know, this can be a real disease and something that we can really manage. So when we start talking about diagnosing dry eyes, let's talk about the whole realm of what we have. You know, one is you want to make sure that you and your patients are aware of the environment. You know, obviously, staring at a computer screen tends to increase the prevalence of dry eyes. You know, we find that people that stare at a computer screen tend to have a lower blink rate, and that's what contributes to the dryness. Same thing for forced heating. You know, you get patients who stick a fan on their desk in the summer and it's blowing in their face all day, and that's what makes them more dry. Or conversely, in winter, they put these little space heaters in their office, and that tends to dry them out a little bit more. I remember back going to optometry school, Schirmer testing. We spent, you know, hours, you know, putting these little strips of pieces of papers in our fellow student's eye. And I found rarely worked back then. In 20 years, I can think of a handful of cases a month where I actually do Schirmer testing. Find most patients aren't real reliable with it. You know, if you don't put an anesthetic in, they get a lot of reflex tearing, so you don't get a lot of good results. You put an anesthetic in and you've got to wait, and even then, you know, results are limited. The only time I really do Schirmer testing now is when you get a referral from a plastics guy for a patient who's going to undergo surgery and they want a Schirmer test documented. Theoretically, you can go to a phenol red testing, same basic concept as Schirmer, but here you're instilling a thread instead of a strip of paper in the patient's eye. So theoretically, I don't know how it is for you guys, but you know, we have a hard time getting any of these things zone quick anymore. And so there's not a whole lot of people that we use this on. But conceptually, it's better. You put that thread in, which is pH sensitive, and you can measure the amount of tears your patient's producing that way. To me, I'm a huge fan of staining. Back in the old days, we used to do a lot of lissamine green staining, then apply this strip, look for areas of conj or corneal staining. I think a lot of optometrists aren't doing that anymore either. Probably the most thing we're doing now to help diagnose dry eyes, aside from a slit lamp, aside from a patient's history, is fluorescein staining, right? Throw some fluorescein into the patient's eye, look for any damage to the conj or to the cornea. While you have the fluorescein in there, no reason why you shouldn't do a quick tear film breakup evaluation, and that'll just give you an idea of how stable that tear film is. If you want to get really fancy, you can go with some of these other gadgets out there. You can measure the amount of tear osmolarity. This company down in Florida produces a product called Inflamadry. You basically take a little sample of that patient's tear, and it'll give you an idea if there's any elevated MMP levels, which would indicate inflammation as part of that patient's dry eyes. You know, in private practice, like I said, I've been doing this 21 years now. You know, a handful of cases that you do this on, to me, is very far and few between. A lot of it's patient history, a lot of it's slit lamp, and a lot of it's just fluorescein staining in terms of coming up with a definitive diagnosis for dry eyes. So our patient, as you recall, had come in with intermittent use of artificial tears, was complaining about redness and irritation. So I educated her, you know, you have dry eye disease, which is what I call it for my patients. You know, using artificial tears intermittently is really not going to work. You have a chronic condition, so you really need to be more diligent about taking these things regularly. You know, taking them once a day as needed is really not going to fix your problem. And so told her to use them regularly. Typically what I'll do in these type of patients, say, okay, let's schedule a follow-up in 3 or 4 weeks after you've used these things twice a day, maybe 3 times a day, depending on how much the dryness is an issue. And then let's see you for a follow-up and see how you're doing. And to me, this is the biggest thing, even though this is going to, bread and butter for most dry eye management starts with artificial tears. A lot of times patients are already taking artificial tears before they come into their office. So, but the worst thing you can do is just say, hey, go down to the aisle and take whatever artificial tear you want. You can have your drug of choice. To me, you always make a specific recommendation to a patient. Otherwise, you could go down to any CVS, any grocery store. The amount of products that are out there are crazy. Inevitably, what studies find, if you don't tell a patient what specific thing to buy, whether it's a steel, whether it's Gentile, Sustain, TheraTears, whatever your drug of choice, your artificial tear of choice may be, patients end up buying the wrong thing. A lot of them buy something like Visine, a lot of them buy an allergy product, because what happens is they get down that aisle and they get confused. They see the thing for Visine saying, gets the red out. And they'll be like, oh yeah, that makes sense. My eyes are red, so I want to get this Visine. Not realizing that their eyes are red because they have this underlying condition of dryness, and they need to get the dryness under control, and that's ultimately what's going to fix their redness. So yes, mainstay for dry eyes is going to be artificial tears, but do your patient the service of giving them a specific recommendation. If you have a sample, that's great. If you don't, write it down. And I've seen a lot of doctors who are proactive about it, they'll write it on a prescription pad, even though it's over the counter, to make sure that patient finds that one specific brand. And that way, the patient gets what the doctor recommends for them. And the question becomes is, what happens when tears aren't enough? There's probably a third of our population who just artificial tears and lubrication, maybe ointments at nighttime. That's all they're going to need to control their dryness. There's a huge chunk that artificial tears won't be enough. And so here, once again, this is by no means an exhaustive list, but just some of the options that we have. We talk about Restasis, we talk about punctal plugs, we talk about steroids, we talk about biologics, and even beyond that. So let's talk about some of these in a little bit more detail. Personally, I am a huge fan of punctal plugs for dry eyes. Rarely do I find a downside to doing punctal plugs. I think patients respond well to them. They're very easy to insert. And the biggest thing is patients don't have to do anything in terms of compliance, and patients notice relief within 1 to 2 days. It takes 5-10 minutes to instill punctal plugs. You go ahead and stick them in, and within a day or two, your patient will know if they're going to get better or not. I rarely do the upper puncta, usually just E2, E4, the 2 lower puncta. Go ahead and include those and see how a patient does. And I know there's been some recent data out there talking about cytokines already present in patients that have moderate to severe dry eyes. Should you really plug them? Because if you plug them, you keep cytokines in their eye longer. I really haven't had a problem with that. If I'm worried about it, I'll go ahead and now RX Rotamax for a day or two before I stick plugs in. Not a huge issue. Personally, back when I first got out of school, I used to have this huge protocol. Back we used to do the self-dissolving collagen plugs as a diagnostic tool. I don't really do that anymore. If I'm going to plug a patient, I want to plug a patient. I find doing collagen plugs really didn't help me diagnostically a whole lot. And when I do plugs, and this is my own personal preference, I like plugs that you can see. It doesn't matter to me what brand. Tear Savers had some, but Vision Odyssey had some. I like plugs that when a patient looks in the mirror, they can pull the lid down, they can see the little white dot in the corner. Number one, it lets me also know if the patient ever has a problem in the future with dry eyes, is it that their dry eyes needs additional therapy, or is it that the plug fell out? And I teach patients that, if you pull that little lid down, you can see a little white dot. If you don't see the white dot anymore, it might have fallen out, which sometimes these plugs do. If that's the case, call the office, let them know that your plug fell out, and be happy to stick in another one. When I do plugs, like to me, patients will get better quickly. It requires very little patient compliance. They just need to be in the office. Patients tolerate it really well. And it's nice revenue generator for practice. Not that it's the only concern when you're talking about managing patients in your private practice. If it's something that's going to help your patient, that's going to bring in additional revenue for your practice as well. To me, very little downside to doing that. Talk about some of the biologics out there. This is a product that came out about a year and a half ago. Regenerize. I mean, it's basically a drop form of an amniotic membrane. Available in 2 formulations, your Regenerize and your Regenerize Light. You know, to me, I'm not a huge, I use amniotic membranes all the time in my practice, usually for trauma, for ulcers, for things like that. Certainly it's another option you have. The downside I find to Regenerize, this is not something that's available through the pharmacy. You generally have to fill out a prescription, you fill out a little order form, and you send it off directly to the company who will bill the patient and send it to the patient. Costs roughly $80, $90, usually prescribed twice a day. So it does work for your patients who need some relief, who aren't responding to some other options. But you know, it is basically a liquid form of an amniotic membrane. Let's talk about the big guns here. Let's talk about Restasis and Xiidra for a minute. We know Restasis came on the market with the concept that patients with moderate to severe inflammation, dry eyes have some inflammation of their lacrimal gland. So Restasis works by decreasing that inflammation. And the concept is that if we can restore the natural function of the lacrimal gland, then the lacrimal gland will start producing tears naturally. You know, when it first came out, Restasis was only available in these single-use vials. In more recent times, we've had this multi-dose bottle. Xiidra, same basic concept, a little different mechanism of action, works by interfering with T cells. Same concept, if we decrease the inflammation around the lacrimal gland, we'll restore their natural function. If we do that, it will get a patient to produce their tears more frequently. BID dosing, just like Restasis is, approved for 17 years and older. Unlike Restasis, doesn't come in a multi-dose vial. Your Xiidra is still in your plastic vials. The advantage of Xiidra versus Restasis, you know, Restasis takes anywhere from 2 to 3 months for a patient to respond, if they're going to respond. Whereas Xiidra, patients will demonstrate some success as early as 4 to 6 weeks. Restasis, cyclosporin A, only available through Allergan. About a year ago, another company called Sun Pharmaceuticals came out with a different formulation of your cyclosporin A, little different delivery vehicle, same basic concept as Restasis. Talk about the role of steroids in dry eyes. You know, I love Lotemax, and sometimes I'll use Alrex too. To me, Alrex and Lotemax are interchangeable. You know, they're the same exact steroid, just a different concentration. You know, the way I use either one of them, whether it's Alrex or Lotemax, twice a day, I use them on what I call pulse therapy. Patients are going through their dry eye protocol, whatever it is, whatever you recommend, and then they'll go through some time period where they'll say, hey, my eyes are bothering me again. And that's when y'all hit them with the Lotemax. Say, look, let's take the Lotemax twice a day, week, 2 weeks, 3 weeks. You know, not something I'm going to have a patient on long term. Get them over that hump, get their eyes more comfortable. And once that happens, you go back to the normal long-term protocol you had for your patient. You know, what makes Lotemax and Alrex, you know, so great in anterior seg disease, you know, we call them soft steroids. But realize that all steroids are derived from the same prednisolone molecule. And what folks at B&L were able to do is take this one side chain, position 20, they changed it from a ketone to an ester. And most optometrists say, well, you know, why does that matter? Well, it changed the safety profile of the steroid molecule. You know, you've all heard what a prodrug is. You know, prodrug is something that's inactive until it hits the body and it becomes active. Well, the way this loprednol molecule works, it's the exact opposite. So when a patient instills a drop of Lotemax or Alrex into the eye, it's already in its active form, and just changing this one side change into an ester. Now, as soon as it hits the eye, the corneal enzymes break it down, and it becomes inactive, And that's what enhances the safety profile in terms of the decreased risk for IOP spikes and the decreased risk for cataracts. It doesn't decrease into zero, so it's still a steroid, so that you're still going to have that risk. It's just not as bad as some of the other steroids like the Predforte and the Durezol. Have you guys had any exposure to this Lacrosert? This is another prescription product for dry eyes. These little cylinders of hydroxypropyl cellulose. This is what the package looks like, and this is what these little pellets look like. They come with an applicator, which is what the picture at the top is. Rarely do I have patients use that applicator, but these little cylinders, and the concept here is the patient's going to instill them into the lower fornix, and over the next 10 to 12 hours, your patient will get a sustained release of lubrication. And what happens with these pellets is they feel like a little piece of silicone. The patient's going to instill them in their eye, so they will have that initial foreign body sensation for about 10 to 15 minutes. But within that time frame, the body heat will soften that little pellet up. And then, like I said, over the next 10 to 12 hours, your patient will get some sustained release of lubrication. After that 10 to 12 hours, there's going to be this jellyfish stuff that's left in that patient's eye, which is a residual from this Lacrosert. So you want to have your patient go in and just fish that stuff out. And where I find this really helps, recommended dosing for this thing is twice a day. I don't really have a whole lot of patients using these twice a day. What I really use them for is my keratoconus patients. I do about 8 to 10 keratoconus patients a month, and this is where it really helps. So what I have those patients do is they're typically wearing gas permeable lenses during the day. When they take their gas permeable lenses out at night, I'll have them stick this in at nighttime right before they go to sleep. That way they don't have that 10 or 15 minutes of discomfort. This thing stays in their eye overnight. That way they're getting sustained hydration of their eye overnight. In the morning, they're going to fish that jelly substance out, and then they're free to pop their gas permeable lenses in. You're going to write a prescription for it. You can just put Lacrosert, 1 month supply, use 1 drop, one pellet twice a day. B&L for earlier part of this year was having some manufacturing issues with Lacrosert. I think most of that is resolved now, so it should be, like I said, just another option you have for your patients.
My clinical pearl for that, Deepak, I have a rheumatology practice. It's a 6-man woman doctor rheumatology practice. I see a lot of Sjogren's patients. I see a lot of advanced, rheumatoid disease. And, the patients think that they can get away with just putting that in there. But you got to tell them to use some tears, because if they're super, super dry, it just never dissolves. So, make sure that if we do use it, that they don't pull it down too far that it falls out, but they have to use a little bit of lubricant to kind of help it self-dissolve and just kind of keep it activated, for lack of a better term.
So one of our newest arsenals for dry eyes is just FDA approved by Oyster Bay Pharmaceuticals, Cerviate. It's a nasal spray used twice a day, and this is a cholinergic agonist. And what it does is it actually stimulates the eye to produce more tears. Used twice a day, and some of the FDA trials show, you can see here about roughly half the people that use this thing, use this nasal spray, demonstrated improvement in tremors testing for their dry eyes. So, up in our area, we haven't actually had it hit the market yet. So I haven't had any exposure to it. And I know Joe or you or Greg have any direct exposure to this yet?
I actually do not at this point. I've got a different gestalt for dealing with dry eye, and I think we'll talk about that a little bit later, but no, I've not had any cause to use this one yet. Greg?
I have an N of 2 right now in my practice. And, what I've figured out with this is that, I had a patient that just couldn't put drops in. They just couldn't put them in their eye. They'd squeeze. And that's where I kind of had the light bulb to go off with this. A little bit of a technique that you got to use with it. One, you don't shake it. It is a nasal spray, but it will cause a patient to sneeze or cough. It's not a spray where you stick it up the nose like an inhaler, spray it and inhale. You just kind of hit right this, I guess, this little lower part of the nose. It hits the trigeminal nerve. It hits the Joe, help me out.
Parasympathetic.
Parasympathetics, and basically creates the tears. Now, what I like about it is that it creates all the tears to produce all the different layers. So my N of 2 right now, haven't had any follow-up, which kind of goes to someone asked the question, when do you do follow-up for dry eye? Typically my follow-up is 3 to 4 weeks, no matter whether it's advanced or severe, unless I'm doing something along the line of, an amniotic membrane. In that case, we're going to do a sooner follow-up. But if it's plugs or, Oxervate or any of these, things that Deepak has talked about to this point, about 3 or 4 weeks, just because the patients will at times kind of mess things up. And I'm just going to kind of keep the floor here real quick. You were talking about artificial tears. The one thing I want to point out is one of the biggest things that came from the DO study was to eliminate BAK. So when you were talking about making that recommendation to the patient about writing it down, give them a tear, remember they're going to put that sustain, that refresh, whatever it is you recommend next to the generic and say it's exactly the same. And the active ingredients are truly exactly the same. However, it's the inactive ingredients, which is the BAK and the generics, that can really beat up the surface. So I just explained to the patient, look, I'm doing this on purpose. I want you to get something that's in a sense branded, because not only are they designer in the fact that it tries to match your tears as close as possible, but it's the BAK that is in the generics that can really beat up the cornea. So let's find out who that is. Mute that.
Can't find him. Oh,
yeah, there it is. So, maybe not. So basically it's the BAK that's out there that we just want to be careful. But back to Tyrvaya, my N of 2, I think it's going to have its place. Stay tuned. It's kind of nice having something a little bit different, attacking a different pathway.
I have a question for you, Greg. How much do you think BAK really matters in dry eyes?
I think it matters a lot. Study after study comes out, if you ask it a different way, how much do I think BAK and a prostaglandin analog, Travatan Z, does that make a difference? To me, no, because you're putting a prostaglandin analog on the eye. That's a mediator of inflammation. Okay. All right. Taking BAK out theoretically is going to help. But when it comes to dry eye, I'm a big elimination, because, the DO study said one of the biggest findings of the DO study was take away BAK, and you're going to help the patient out.
So we looked at the most common stuff in terms of things you can do in artificial tears. There's a whole lot of other stuff. You look at omega-3s, we've got so many studies out there showing nutrition is another way you can help your patients who have dryness. Second thing on this humidifier. I think, to me, in my practice, I found patients going to a Walmart or Target, spending $30 on a humidifier, putting that in their bedroom has helped as much as anything else. You figure that's the one room in your house where you're spending 6 hours, 8 hours, 10 hours, whatever you're sleeping. You put you increase the humidity in that room. Now you're getting an eye that's, instead of dehydrating overnight, it's getting nice and moisturized overnight. Patients don't wake up as dry. I think that helps as much as anything else. I put warm compresses on here. I find, obviously, you're going to rule out any blepharitis, any meibomian gland dysfunction. Even patients who I don't think have any those true things going on, I find having dry eye patients do warm compresses when they're in the shower every day makes a huge difference. And here, I don't go with baby shampoo or any of the lid wipes or anything. Just tell them, look, put a washcloth in the shower, and when they're taking that shower, take that washcloth, massage the lid margins with some warm water. And I find, that helps my patients with dry eyes as much as anything else. Another option, it's one of those things that's not for every patient, obviously, but if you get somebody who's gone through a lot of your other therapeutics and hasn't gotten the relief they want, these autologous serum tears. When I was in Connecticut, we used to send up to Yale all the time. I have University of Rochester, which is 15 minutes up the road. And sometimes, what this is, for those of you who aren't familiar, you basically, take a blood sample from a patient, you spin that blood down, and you go ahead and make artificial tears out of that blood. And, you'll get patients that'll respond to that, as much sometimes when they haven't responded to anything else. Joe, Greg, I don't know if you guys had any experience with this. I'll use it maybe once or twice a year.
Greg, what are your thoughts? I know what my feeling is here.
Yeah, I mean, I use, everything you said there, the omegas, the humidifiers, but if you're going down kind of the autologous blood serum, again, being near this rheumatology practice, I see a lot of advanced rheumatological cases. So now we're talking the lupus, the Wegener's, the mixed connective tissue disease, the Sjogren's, and adding, they're autoimmune. So now adding these things that you talked about so far, Xiidra and Restasis, it's best to have something that's natural for this patient. I use Vital Tears all the time, and works really, really, really awesome. They actually, you prescribe it, they send a phlebotomist right to their house for $20. They make up the tears, and I can't tell you how many people that in these kind of autoimmune conditions that I've used an autologous serum. You want to do 20% of the serum. It's 6 times a day or more. And it can be life-changing for the patient.
I agree with that, Greg. I'm in a point where I either recommend or use autologous serum, Vital Tears, about once a week. In fact, I recommended it to a patient today for moderately severe dry eye, and she didn't buy into it initially, so I went to a steroid, Lotemax. I'm going to bring the patient back after 2 weeks of Lotemax. We're going to see how she's doing with that and her artificial tears. But I myself would like to use autologous serum on her. These are the patients who have a fair amount of staining. Dry eye is not a by the way type of complaint. It's their chief complaint. Their pre or post cataract surgery. I think that autologous serum is great. I mean, I've used it as high as 40%. Usually I do between 20 and 40. But it's just extremely helpful. The neurotrophic growth factors, I'll use that if I can't get oxyrvate for neurotrophism. I think autologous serum is probably underused, and I think really quite highly of it. It's really very effective.
Yeah. The only drawback is, it's a cash paying. I forget how much it is. I usually tell them to get the 600 or get the 6-month supply. It saves them about $90. I think it's about $100 a month. So it's not really covered by insurance. I'm really not sure about health savings accounts, but it works great out there. There's some questions rolling in here about Isuvis. It says, do you like Isuvis? I've been using it lately. Someone rolled in and said, I have 3 or 4 patients on it, and 2 have noted improvement. And I can tell you, I tell the patients, look, I've been waiting for this steroid to come out for years. It's 0.25% loteprednol. And, I think a lot of us on the market would say, geez, here's just another loteprednol that's out there. I think when I put my slide together for my update in pharmaceuticals, I think there might be 7 or 9 Lotemax on there, protocols, and Deepak hit it beautifully with that carbon 20, changing it to an ester. And there's a lot of plasma cholinesterase on the eye that kind of breaks that down to kind of keep it at the front of the eye, not really getting to the back of the eye. But what Kala did on this is they did 2 things to really help out with that 0.25%. Is that they made it a nanotechnology. That molecule of that loteprednol is 300 nanometers, which does a few things. It allows it to go through that mucous membrane to get into the cornea tissue, the lacrimal gland, into the conjunctiva. Now, they didn't stop there. I think they call it amplify or something along that lines. Take that with a grain of salt. We can look that up later. But basically, amplify is a slime. It's a coating that wraps that molecule to not only allow it to be small, and small is good because small allows it to quickly diffuse across the eye. Quick diffusion, penetration, and that then allows it to really, really work well. So those that are out there that are talking about Isuvis and 3 or 4 patients on it, noted improvement. I've been having great improvement that's out there. with it. So I would encourage you not to lump it into just another load of prednisone. It is a little bit different in its mechanism of delivery, not mechanism of action. I'm done.
So if you recall, let's go back to my patient, who was a dry eye patient who was intermittently using tears, who I recommended using tears more regularly. Then I saw her for 3 or 4 weeks for a follow-up. At that point, she wasn't any better. So put her on the Restasis protocol, which, if you're going to start a patient on Restasis or Xiidra, we'll always start them on Lotemax, for the first month or two at the same time, eventually take them off the Lotemax, then keep the Restasis. So after 6 weeks, I discontinued the Lotemax. At 3 months, she's absolutely no better. So the question here is, what did I do wrong? So I find a lot of optometrists do this when they put a patient on Restasis. And, so when I'm going to tell you what I did wrong, which I think a lot of optometrists do wrong when they start prescribing Restasis, is they put too much faith in Restasis. I know back when Restasis first came out and it was marketed, and, you would put a patient, you would go through the protocol, and 3 months down the road, patient would be no better. And, the reason was always one of two things. It was, well, my patient probably didn't do what they were told to do. That's why they're not better at 3 months. Or, well, it hasn't kicked in yet. Let's wait another 3 months. And by then, in 6 months, from the initial onset is when it'll work. And you do that enough times and you realize, okay, I can't have that many non-compliant patients. And I can't have that many patients who it's actually going to take 6 months for it to work on. So you go back and you do a little bit more research. And so when I did this about, probably like 2.5 years ago now, I was actually shocked. When you find out the most common reason for failure for Restasis, if you ask the average eye care provider, they're going to say it's non-compliance by the patient. It's really not non-compliance by the patient. If you're ever bored, you want to Google the prescribing information for Restasis, you'd be shocked to find out that Restasis failed in the FDA clinical trials the first 2 times it was presented. And the third time, when it finally got FDA approved, it only got a 15% response rate, as compared to 5% for a placebo. So when you think about these numbers, I'm always amazed at how this billion-dollar drug, is FDA approved when 85% of patients that you prescribe it to are going to fail. And those aren't my numbers from my practice. Those are just numbers from the FDA clinical trials. You can certainly look those up. And then you go, outside of this country, you find that Restasis wasn't approved in many countries because of this low response rate. And you say, well, all right, that's Restasis. How about Xiidra? Xiidra is a whopping 17%. Once again, compared to a 5 to 7% for placebo. So when you think about those numbers, it doesn't mean you don't prescribe this or you don't have it in your arsenal in terms of what you can help your dry eye patients with. Just keep that in mind next time you have a patient who 3 months into your protocol or 6 months into your protocol doesn't get better with Restasis or Xiidra. Just realize that 4 out of every 5 patients you put in there really aren't going to get better. And that's just based on the clinical efficacy of the drug. So to me, Restasis to me has gotten way further down on my protocol in terms of what I would do for dry eyes, partly based on that. Greg, Joe, I don't know if you guys have any different feelings on it.
Joe, I have a comment, but if you want to go first, go ahead.
Oh, go ahead, Greg.
So, I agree with Deepak 100%. The Allergan reps are not in my office because of Restasis. They're in there because of the prostaglandin, Lumigan, Combigan, and maybe some Alphagan. They're definitely not in my office because of Restasis. My clinical pearl out there would be, if you're going to use it, use the whole vial the whole day, and maybe 2 vials, right? That's what Sun did. Sun took the concentration from 0.05 up to 0.09. So it basically doubled the concentration, changed the mechanism of action, kind of put a slime around it, because cyclosporin is a fat-loving molecule. You're dropping it into a watery eye. So water and oil don't mix. So it's very hard to get this medication to it. So if you're going to use it, what I found out a successful way is, why twice a day? You're not going to kill the person with cyclosporin. I just use the whole vial all day long. It's supposed to throw it away because you're supposed to touch the blah, blah, blah. Tell them to put it in a safe place. Tell them to use the 6 or 8 drops that are in the vial. They have to overfill it. And if they want to use a second vial, kind of drive that medication. Cyclosporin works. We see it work in veterinarian clinics all the time. It's just a higher concentration. It's a low dose for us. Just use it all and you'll get some higher successes out there. But again, I'm not a big prescriber of it.
That's actually an excellent pearl there, Greg.
So to me, we sum up dry eyes, to me, a couple of my pearls, like I said, over 20 years, you always schedule a patient for a follow-up. There's never any downside to doing that. Patient comes back for a follow-up, one of two things are going to happen. One, you're going to get confirmation that your diagnosis is right and your management protocol is right, the patient's doing well, or the patient's not going to be doing well. And at that point, it's going to give you an opportunity to talk to your patient about other options that they have. And, to me, that's a very important reason for it. And like we've talked about before, there's many different options when artificial tears aren't enough for your patient. Your job is to find the right one. It's not a sequential line where you go from A to B to C to D. You do whatever fits into your patient's lifestyle, whatever is going on with the patients in terms of dryness. For some, it may be plugs. For some, it may be rhistasis. It may be amniotic membranes. It may be, whatever it takes to get your patient's dryness under control. Your job as their primary eye care provider is to find the option that's going to best suit that patient's disease. Any questions about dry eyes? Any comments before we?
Well, I think we're heading to the very final couple of minutes here.
Yes.
And Deepak, we do appreciate you letting us get involved and having discussions with you. So I think the question I want to bring up that we didn't really cover much about is where do amniotic membranes fit for both of you fellows in the severe dry eye? Or is that too extensive for dry eye? What are your thoughts, Deepak and Greg?
Personally, I don't use amniotic membranes all that much for dry eyes. I use them a lot for other conditions, non-resolving ulcers, trauma, things like that. For me, for an amniotic membrane for dry eyes would have to be 3rd or 4th down the road when other things haven't worked.
Greg, what are your thoughts there?
Yeah, two comments on amniotic membranes. The first one is if it's a neurotrophic, and that's, Oxervate has brought corneal sensitivity testing. Dry eye patients can start moving down that route of desensitize. So if it's a desensitized cornea, basically from a dry eye patient, I will reach for an amniotic membrane that's out there, maybe even before going for Oxervate or something along that line. Certainly, it's not my number one use for an amniotic membrane. Definitely needs to be in the tool belt of all the things that we've been talking about tonight. For those special patients that have this dry eye, yes, an amniotic membrane. But I will caution people out there, Deepak mentioned about things like infection. I have an hour lecture on amniotic membranes. And if you look at the package insert of your dehydrated, I encourage you to do it if you have them in your office. They're contraindicated in infectious keratitis. There is a difference, despite what the reps say out there, between a dehydrated and a cryopreserved. Those are the two categories that are out there. Cryopreserved does save a few biologics. Pentraxin 3 and heavy chain hyaluronic acid are the two big. Look those up. Heavy chain hyaluronic acid, Pentraxin 3. Two important biologics that are important out there that get lost in a dehydrated process. My point of this rattling on is don't put, or just read the package insert. If you're going to use it for an infectious keratitis, make sure you're using a cryopreserve because it actually is indicated on the package insert, as opposed to a dehydrated is contraindicated. Might be a little hard if that ulcer goes south on you and an attorney gets that package insert and says it's contraindicated. Why did you use it? That would be my reasons to kind of help you guys out with that. But dry eye, Joe, or Deepak was the question. Use it, but it's got to be a special circumstance.
I agree with you. I am more at a serum tier or autologous serum person when it comes to the severe dry eye. I don't think I don't often or really consider amniotic membranes, but they are fantastic for a lot of other situations. Deepak, I think we're just about out of time. Is there anything you want to wrap up with?
Yeah, I'll go through this real quick study. You'll see it. It'll take me 2 minutes.
Okay.
So our last patient, it's kind of funny. Your technician informs you that you have an emergency patient complaining about a red irritated eye. You look in your exam room. You look in your waiting room. What happened here? What happened here is that you failed to practice primary care optometry. Therefore, you have no emergency patients. Don't let this happen to you. That I've been practicing optometry over 20 years. That I do full scope optometry. I highly encourage every optometrist in the country to do the same. You can do routine care, you can do glasses, contacts, you can do it all. And we're in a profession, you can do that. Number one, you'll enjoy yourself for the 30 years or so you're going to practice. You'll make more money and you'll keep our profession progressing forward. So that's my last patient. And I want to thank you guys all. Joe, Greg, thank you for allowing me the privilege of doing this. And for the rest of you, thank you for spending the evening with us. I really appreciate it.
Well, thank you, Deepak. I enjoyed hearing from you and getting to chat with you and Greg on this topic. So Deepak, if you want to or stop sharing your screen, I'll take it over.
Okay.
And you're getting your virtual round of applause. So I'm going to share my screen here.
Yeah, and I just want to grab the comment here, Joe, as you're doing
Okay.
that.
Go right ahead.
Someone said, Michael, yeah, I find most dry eyes to involve meibomian gland issues versus tear volume. Yeah, and we could have a full 2-hour talk, Michael, on dry eye and meibomian gland dysfunction and rehabbing that meibomian gland versus the evaporative side of it that's out there. So I agree. We didn't really touch much on the meibomian gland, but we can certainly kind of do a whole even hour lecture on there with the things like tear care and expressing and using doxycycline to normalize that meibomian gland. So that's a great point.
Excellent. Yeah, if you're treating one and not the other, you're not going to have much success. Well, thank you, Dr. Deepak Gupta, for anterior segment disease, or every optometrist should know. I really enjoyed hearing you, and we certainly enjoyed